Welcome to TRI Innovations for May. This is the last one we're having this year. It should pick up back again in the fall. And I know Dr. James wants to move this to a once a month seminar. So please keep an eye out for announcements for our renewed innovations in the fall, and look for great speakers for that. I know we are changing it to be, I think, 4 to 5, so maybe a little bit better time. And we should have more a variety of speakers. So we'll continue on and get to hear from more of our awardees. So today we are excited to welcome some of our Team Science awardees. These people represent groups that were given some funding to help their teams achieve some of their goals in research. It's a little bit different than like a pilot where we're funding the whole program, but we funded just like a piece, give them some money so they can sort of fill a piece or a missing gap in something that their team needed. But they're going to talk to us about their research primarily, but I did want to clarify that these are awardees from our Team Science program. We have Dr. Fawcett here, Dr. Larson Pryor, and Dr. Hayes. Okay, so in a minute, I'm going to stop sharing my screen, and then I'm going to turn it over to Dr. Fawcett, who'll be our first presenter, and I'll let her drive and do her presentation.
Great, thank you very much. I really appreciate the opportunity. Okay, so Dr. Vera Pandian, Dr. Sorensen, and myself wanted to look at some things that were going on with some Duchenne and Becker muscular dystrophy patients. So I had just kind of mentioned off the cuff some things that I had noticed, and we found this award, and so we applied, which was kind of out of everybody's wheelhouse. They really hadn't done much with nutrition, and I hadn't really done much with neuropsych and neurology, so it was really fun. So I wanted to go ahead and start and just tell you a little bit about Duchenne muscular dystrophy and why it's really important to me and my research and my passion. I have an 11-year-old son who has Duchenne muscular dystrophy. So it's very close to home, and I see a lot of gaps that need to be addressed, especially here in the US relating to nutrition and alternative and complementary medicine. So I want to talk about what it is, and then signs and symptoms, diagnosis, the causes, inheritance, the medical management, and then get to the research. Okay, so it's a genetic disorder characterized by muscle degeneration. Basically, the proteins in the muscle called dystrophin just isn't there for these boys. It's a 1 in 4 condition known as the dystrophinopathies. That's a big one. And it's usually onset in early childhood between 2 to 3. A lot of times we're seeing diagnosis earlier now because they're testing at birth versus 5 or 10 years ago where they weren't really noticing it until signs and symptoms presented themselves. And then in Europe and North America, the prevalence is 6 per 100,000, and that's from MDA. But a lot of other sites are saying 1 to 3,500 boys. And it does happen in females, but it's very rare, closer to like 1 in a million. So some symptoms, muscle weakness is the biggest sign. So you're first going to notice those proximal muscles being affected, the ones close to the core of our body, and then the distal ones at a later date. They typically affect the lower half of the body first. So we see degeneration in the legs, and then the lower body first, and then upper arms later. And a lot of times, one of the first things that parents will notice before they come in to look to see if to assess if their kids need to be tested is these boys do this movement called a Gower's maneuver, which is basically where they like walk their body up their legs and their trunk because they don't have the muscle strength to stand up on their own. Some other things that you might notice are they have difficulty running, jumping, just doing normal things, stair climbing. And then you're also going to see those enlargement of calves, waddling gait, lumbar lordosis, so that inward curve of the spine. And then later we're going to see heart and respiratory muscle and dysfunction, and then pulmonary function decline. So the diagnosis, basically the easiest way to diagnose is these kids come in and they do a CK and other enzyme level tests. So these CK levels usually are, sorry, I have some notes, but let me just pull up really fast. Usually for just normal kids, they're about 200, but when Duchenne boys or Becker muscular dystrophy boys end up coming in, it's typically 10 to 100 times greater. So it's significantly higher. And then they'll do a genetic testing to determine, and they a lot of times do a muscle biopsy. So Decode Duchenne does a really good job on genetic testing for siblings of boys with Duchenne. So for instance, if they have a sister, sisters typically can be carriers, but they don't present symptoms. So Decode Duchenne does a great job of genetic testing at very, very limited cost, and sometimes no cost at all. So there's a lady, her name is Dr. Singh, and she's a medical doctor, and she does these cartoons. And basically, she did these cartoons to help her med students learn about different disorders, and she does a great job. She's such a neat lady. So this is just a little slide of kind of explaining what muscular dystrophy and Duchenne muscular dystrophy and Becker muscular dystrophy is. So they're going to have poor balance, like I said, lordosis. They're going to have that protruded belly because they have very weak abdominal muscles. They're going to walk on their tiptoes, and then eventually their Achilles tendon will get so tight that they won't be able to have any flexion or extension. And then those big calves are going to be very prominent. What do? We treat it with steroids. We use physiotherapy, and we do braces, and we also do like stretches and things like that. But one thing that we're really missing is we don't ever talk about nutrition in these boys. In other different parts of the country, Australia, for instance, they're doing a lot of research, or there's a dietitian that's a PhD researcher named Zoe Davidson that does a really good job. And we've been working on some things to try to see where we could maybe work on that to try to build up our nutrition for these boys. And this is just another slide explaining kind of what DMD looks like. She does a really, really good job. She has a website that does all kinds of disorders. And I actually talked to her the other day, and she's like, if you ever have one that you want one done for, just let me know. So great resource if you're trying to teach somebody, maybe a lay audience, something like that. So causes, it can be a mutated DMD gene fails to produce virtually any functional dystrophin. And many cases are caused by the part of the gene that encodes the middle section. So typically we see these boys that have these deletions that are maybe on one exon or one little part of it. And then we have some boys that have these deletions that are very large. For instance, my son Tyler has a deletion from 45 to 63. So it's a rather large deletion. So not only does it affect him physically, but cognitively. So that is where Dr. Sorensen came in, and we really wanted to look at what was going on with these boys socially and emotionally and cognitively as well. In addition, the absence of dystrophin, they begin to form in the muscle, and the muscle just becomes really fibrous and dense, and basically it doesn't stretch anymore. Inflammation increases, and then the muscle gets damaged, basically scar tissue forms, and then it no longer will work. So it's inherited in an X-linked pattern because the gene that carry a DMD-causing mutation is on the X chromosome. That is why boys are mostly affected. So if a mother's a carrier, she has a 1 in 2 chance of having a boy with Duchenne. We have several families at Arkansas Children's that have multiple sons with Becker and DMD because, like I said, diagnosis has just now recently become where we're doing it closer to birth and things where 5-10 years ago, they didn't know until they'd had 2 or 3 children. So we've done a really good job with that. Carriers may not have any signs or symptoms, but they can have some cardiomyopathy later in life. So it is important for female carriers or females in a family member to get tested and be aware, especially if she is considering having children at some point. And there is a thing they call spontaneous mutation, but it really isn't spontaneous. It's just more that maybe DMD had happened prior in someone's ancestry. We just didn't know what it was, or we didn't know how to diagnose this. You know, if you think about muscular dystrophy in its essence, it's not been that long that we've been looking at that and researching it. So medical management here at Arkansas Children's, when a boy is tested and diagnosed, he then gets to see a multidisciplinary team. So I've been very, very lucky to have worked with this team in clinics. That's where we've actually done our study. And that's kind of where all this is sort of become a huge passion of mine. So they'll see a neurologist and a cardiologist, a pulmonologist, a neuropsychologist, and they also see a rehab medicine, and then they see ortho if they need, they see physical therapy, occupational therapy, speech therapy, and they can see a dietitian if a provider thinks it's necessary. However, I think that that's a big part that we're missing. So many of these boys are overweight or underweight. It's kind of the two ends of the spectrum. Either they're way below the growth curve or they're way above the growth curve. Usually with DMD, it's above the growth curve, and Becker, it's below. So before they get to that point where it's really on the outskirts of it, we want to try to remedy where we can help them establish better eating habits, nutrition, things like that. And there's some other things that are done in therapy that maybe they're not realizing how important nutrition could be, such as they are all on vitamin D supplements, but we rarely talk about how their calcium levels are. They're on steroids, so blood glucose can be an issue. And later, cardiomyopathy and pulmonary issues are typically what does, this is a terminal illness. So that is what causes these boys to move on. So research, right now they're doing some really, really cool things with research in medical models in mice and with exon skipping and gene skipping and things like that. They're inserting new genes, they're controlling how cells read genetic instructions, they're repairing muscle tissue, they're helping muscles regain from damage, they're combating inflammation, they're blocking fibers, they're maximizing blood flow, and they're trying to protect that dystrophin deficient heart. But what are we not doing? And that's where I really see a need to have a dietitian as a very, very intricate component of these boys' multidisciplinary team, due to the fact that nutrition is very important on so many levels. So Dr. Panda and Dr. Sorensen and I kind of started brainstorming what we thought would be important. And a lot of times when you're dealing with nutrition and the family setting, you have to realize, okay, well, what's the whole situation? You know, who is buying the food? What are the reasons these kids are overweight, other than we know they're on steroids, we know they're non-ambulatory, things like that. So we wanted to explore the food habits, the dietary practice, how they parent, the perception and beliefs of the patients and the family members. So that includes mom, dad, or grandma, grandpa, whoever is that intricate part of that child's life, siblings, how they feel relating to nutrition and weight changes in the children with DMD and Becker. So we wanted to assess the correlation of parenting style and practice with body mass index of these boys. And then we wanted to study the influence of the psychosocial and neurobehavioral factors on dietary practice and children with dystrophinopathy. So basically our hypothesis was a lot of these boys have very permissive parents due to the fact that this is a terminal illness and these children are at a shorter lifespan. So parents tend to want to do everything they can to provide the best life. And that includes maybe giving in a little bit where they shouldn't. You know, these boys don't have the opportunity to play as, you know, atypically or typically as they normally would. So sometimes we associate happiness with food, which we know is not necessarily a positive thing to do, but we see a lot of boys eating very poor diets. So we did a prospective observational study. This was basically what Panda and Dr. Sorensen and I just kept saying was a fact-finding mission. We really hadn't done anything like this in any of these patients, so we just kind of wanted to assess how they felt about things and if they were open to things. And we recruited from the population that was already going to clinic. So we recruited DMD and Becker, and there were 75 patients that they have in clinic. And we thought for sure everybody would want to be a part of it. We did not have great results, actually. We included boys between 6 and 18, and then each boy was considered an individual, and his parents usually were the ones that filled out a lot of the questionnaires, because a lot of times these boys, especially if they have a bigger deletion, don't have the cognitive function to read, to assess things like that. So the demographics, we ended up having 8 families participate. And we haven't really done a lot of analysis yet, so I just kind of jumped in and got a couple of things out for us. We had 15 families. They identified as white, 2 as Hispanic, and 1 as African American. 16 were married or remarried, and 1 widower and 1 divorced. The average income, and we had the parents fill out a maternal demographic and a paternal demographic questionnaire. So sometimes the paternal side was the breadwinner or the one that went to work. We had a lot of homemakers in our female population. So that is the discrepancy between the income. So the average income you could see was lower for the mothers than the fathers. And then we looked at education level as well, just to see how that kind of correlated with some items that we don't have analyzed yet. And then overall, it was that they shared the responsibilities as caregivers if it was a 2-person home. Typically fathers did more of the maybe manual things like moving, transitioning things, and mothers did more of the emotional support and things like that. And it's very interesting. We found that we have several fathers that are the boys live with their father and their mother is out of the picture, that they're remarried to another woman. So the mother that was the carrier has left the family unit. So that was really interesting, that we kind of wanted to explore maybe at a later date, just what the kind of connotation was with that. So we did multiple questionnaires. We had a socio-demographic questionnaire. We did 3-day food records, and I'll talk about that in a second. We did the child eating behavior questionnaire. We did the Alabama parenting questionnaire, which is very similar to the Baumrin parenting style. We did perceived stress, patient health questionnaire, a generalized anxiety questionnaire, a child and that's on there twice. Child and adolescent sleep checklist, the pediatric symptom checklist, psychosocial adjustment and role skills. And then Dr. Sorensen did neuropsych with the WASI, the children's memory scale, and he did a multilingual aphasia examination. So all willing youth received a brief neuropsych screening, which was a very big benefit for those that participated, because the wait to get into the Dentist Development Center right now is over a year. So it was kind of a really good incentive that just happened out of our study for these participants. So a couple of things that we did get to just pop in really easily were the anxiety, and these were parents' perception of their anxiety of their children. So unless it is noted, such as it says parent up there, these are all assessments of their child from the parent's perception. So the measure of anxiety in these boys, parents assess them as mild and moderate, and 1 severe. The measure of stress was moderate to a lot of high stress level. Parent stress level was interesting, that mostly it was moderate, and then depression, minimal and mild levels of depressive episodes. Things that we haven't had time to analyze yet are all those other questionnaires that we have. And we have the opportunity to look at a lot of medical data to see what else we can find that relates to this. But the one thing that was probably my biggest, I guess, hindrance was having a 3-day food record. I thought that they would want to tell us about their diet and eating habits, which is not the case. So that actually limited our population a lot, because people just didn't want to be in the study knowing that they had to do a 3-day food record, whether it was the time it took to just write it down, because they typically are a pretty detailed analysis. And I was the one performing all of these, so I was calling and finding out, and people just weren't interested in doing that. And there were some other ones that felt very threatened. They didn't want to tell us what their kids were eating because they knew that their child wasn't eating great. So there's a lot that goes into research with nutrition and the judgment people feel. So that's something that I want to consider for future research studies, is maybe sticking with something like the child eating behavior questionnaire or a food frequency questionnaire that's not a detailed analysis. So limitations and some pitfalls that we've already noticed that we've had: the low response rate. We really thought there would be a higher level of response. We did it in clinic, which we thought would be, oh, they're already in clinic, they're already doing this, it's just one more little added thing. But we noticed that it became very, it was difficult for the parents to kind of sit down and take the time to answer the questions in between a clinic visit, because they had multiple practitioners kind of coming in and out. So that wasn't the best idea, which we will most certainly think about for next time. Also, the parents felt very uneasy, like I mentioned, answering questions related to diet and nutrition. And multiple people just wouldn't even participate in the study without knowing that they would have to do a food record. And then also we noticed that the most compliance was from those patients that are high functioning, which kind of, from Dr. Sorensen's standpoint, is a little bit disconcerting, because we want to see what those lower functioning parents and patients are looking like. Like, do they have higher levels of stress because maybe they don't have the ideal coping mechanisms, things like that. So that was kind of an issue that we've encountered already. So some future directions: we've already started getting some data in there and analyzing it. We have some ideas for some manuscripts, and then we actually are looking at an interventional study looking at these things and affecting parental perception and practices. So doing kind of a multiple component of a education-based and a motivational interviewing coaching style counseling with these patients. And then ultimately, my goal, kind of taking on this role in research, is to change the face of the standard of care in relation to nutrition and dietetics. So I am finishing up my dietetic internship right now with The Ohio State University. So my goal is to ultimately become a practitioner that does research, with rare diseases and focusing on specifically neuromuscular diseases. So that's kind of fun. What questions do you all have for me?
So, Kindan, I was interested in the inflammatory response. So you talked about the fact that there's an inflammatory response to the fibrosis that is occurring in these children. And we know basically from aging studies that chronic inflammation is in and of itself kind of a add-on degenerative function. Do you know anything more about that? Not only that, but we also know that diet can impact inflammatory responses. And I just wondered if you had sort of thoughts, information, et cetera, on that particular aspect of the disorder.
Yeah, we don't have that information right now, specifically with the population we're working with, just because we've never explored any of these things. But that's something that I was actually thinking about, looking at the C-reactive protein, and what if we did change their diet? What if we went to a more Mediterranean style diet to decrease those anti-inflammatory properties? I know that there's some other research done in other countries, but it's not really been focused on in nutrition with these boys. So I think it's kind of open to so many opportunities. But thanks. I appreciate that.
Well, seeing no other questions, we will go ahead and move on to our next presenter. Thank you, Dr. Fawcett. That was really interesting. I enjoyed it. Our next presenter is Dr. Hayes. So we're going to turn over the floor to him and he can pull up his presentation.
Hello, everybody. So as Nia said, my name is Corey Hayes. I'm an assistant professor in the departments of psychiatry and biomedical informatics and a research health scientist within the VA. And I'm going to talk about my Team Science Voucher Award, which was around developing and validating PREMAT, a predictive model for MAT dropout among veterans with an opioid use disorder. So, of course, as the announcement noted, this is certainly an area in which it takes a team. And so I just wanted to first off introduce the team members. So the team members for this particular study were Dr. Voucher, who's a psychologist within the Women's Mental Health Program in the Psychiatric Research Institute, who treats patients with opioid use disorder, particularly postpartum women. Brad Martin, who's a professor in the College of Pharmacy, Pharmaceutical Evaluation and Policy. Keith Bush, who is a computer scientist by training within the Brain Imaging Research Center in the Psychiatric Research Institute, and does a lot with machine learning. Adam Gordon, who is a internist and addiction medicine physician out of Salt Lake City, Utah, and then Bo Hugh, who is a biostatistician for our group. So the reason we made moves in this area of working on the predictive model is because the opioid epidemic is obviously a huge issue. And what we've seen as a result of the opioid epidemic is that the number of veterans diagnosed with opioid use disorder has nearly tripled over the last 15 years, and this would be the case as well in civilian populations. And we've made great headway in the treatment of opioid use disorder, which, depending on the term you use, is called medication-assisted treatment, or MAT, or MOUD, medication for opioid use disorder. And there are currently 3 approved medications for opioid use disorder. These include buprenorphine, methadone, and naltrexone. Certainly the current most prevalent medication is buprenorphine. The reason for that is it's shown similar efficacy as methadone, but it can be dispensed from community pharmacies, making it more accessible for patients. But MOUD, or MAT, is the standard of care of treatment for opioid use disorder, and it's certainly been shown, all 3 of these, to prevent overdoses and reduce drug use within this population. However, to get those important endpoints of reducing overdoses, drug use, and keeping patients in treatment from those mortality endpoints, you have to keep patients in treatment. So MAT retention is essential to obtaining these outcomes. Unfortunately, one of the problems that we're faced in veterans and in civilian populations is that only 50% of those who start buprenorphine actually continue it past 6 months of treatment. And what NIDA has said is that most patients need at least 6 months, really a year of treatment at minimum. And there's certainly a big discussion in regards to, is this not a lifelong medication, which a lot of addiction medicine physicians believe to be the case. So our premise for this is that predictive modeling is a real-time method that can estimate a person's probability of experience and outcome in the future. So this is a way in which we can get at who might have this outcome. And the outcome that we're talking about for this particular issue is whether or not they would discontinue their medication-assisted treatment. And the VA, we pointed in the VA for several reasons for this to start with, but one of those is that the VA currently uses clinical decision support tools in identifying veterans at high risk for opioid overdose or suicide to determine which patients need additional care for those metrics. And some of their preliminary evidence on these decision support tools have been fairly promising. So, for example, the VA has shown that they've had a decrease in 6-month all-cause mortality by about 25% among those who are at high risk for suicide within the VA by implementing what they call BreachVet, which was their clinical decision support tool-based system on the predictive model of high-risk veterans for suicide. So really the question that we had is, could we use this framework, this idea of using a predictive model, wrapping it into a clinical decision support tool to help guide clinicians? Could we use that framework that they've been doing that in the VA for overdoses and suicide to keep patients in treatment for medication-assisted treatment? So the Voucher Aim that we set out to do within the Team Science Voucher was to develop and validate a prototype of PREMAT, this predictive model for MAT dropout. The method that we used for this was a multivariate logistic regression to develop and validate the model. And we used a national sample of veterans diagnosed with OUD who were initiating a new episode of MAT with buprenorphine. And so what we did is so the VA is the largest integrated EHR system in the United States. And so we had a large number of patients there. And we created multiple variables using that EHR data that were driven by the previous literature and other, just predictors that we thought might be driving some of this dropout. So we explored demographics, age, race, marital status, which was great to have within the VA, as well as a lot of clinical characteristics such as mental health diagnoses, polysubstance use, ED visits. And we created PREMAT to provide the predictive probability at the baseline, so the first date in which they initiated buprenorphine, as well as looking at, as they continue into treatment, how well does our prediction get? Or how much does our prediction improve? So we assessed the predictive validity of these models using various different metrics, statistics, sensitivity, specificity, and we used those metrics at the UDIN index, so it's just an index in which it maximizes each of these predictive validation statistics. So for our logistic, we use a stepwise logistic regression model where the variable had to have a p-value less than 0.2 to enter the model and was only kept in the model if the p-value was less than 0.1. And to do this predictive validity, we split our sample into training and validation cohorts. And so this was a 50-50 split of the patients within our sample. So 50% of the patients went to train the model, and then the other 50% was used to validate the model in which the model was not trained. So the results that we have, we pulled VHA corporate data warehouse data from the EHR nationally from 2006 to 2019. And we looked at many different files within the CDW, which included some administrative files such as their benefits, did they see combat? This includes their age, their race, all of those types of things, as well as their outpatient, inpatient visits, vital signs information, which usually includes like pain scores, blood pressure, as well as their pharmacy information. So here's the flow of the inclusion and exclusion criteria. For the sake of time, I won't go through this. Over this time frame, we had about 300,000 patients who had an opioid use disorder. Unfortunately, we're not doing great in getting these patients initiated on buprenorphine. So if you can see down my 1, 2, 3, 4, the fourth block, only 43,000, almost 44,000 of these patients actually initiated buprenorphine in our study time frame. So, again, hopefully this percentage is improving over time, but we weren't doing a great job for sure in the early time periods of buprenorphine care. Implementing other exclusion criteria, and talk about these later if we want to. What we ended up with was about 15,000 patients in each of our training and validation cohorts, respectively. So like I said, we had about almost 30,000 patients who were split 50-50 between our training and validation cohorts. Of that sample, 51% actually completed a 180-day course of buprenorphine. So this is a lot of where we're getting our pilot data on 50% of patients are actually completing the course at 6 months, which is similar to other published literature. And we developed a total of 713 candidate predictors that we explored within our modeling. And this becomes important when you're talking about such a large number of predictors to have a large number of patients, because you have to have at least 10 patients per predictor for exploring these. So here's a look at some of our preliminary models using the logistic version. So we created a model where we included only data from the 365 days prior to their buprenorphine initiation, which we're calling their index date. And we looked whether or not the patient was retained in treatment on buprenorphine 180 days later. And so you can see our validation statistics here. What you're wanting is at least a C statistic of about 0.7, really about 0.8 is where you're hoping for. And so as you go through each of these models, as we include a little bit of a time frame in their initial treatment episodes, we get pretty drastic increases in the predictive validity of our models. And I think what this means is like the first, what it boils down to is like the first week or 2 weeks of seeing these patients in clinic and getting them initiated on buprenorphine has a huge potential for either keeping them into treatment or risk for having them drop out. So those first 2 weeks become really vital. And I think that means that we have some area to work on improving retention with this type of modeling and decision support tools, in hopes that if we can get them to stay in that first 2 week period, they will likely stay for much longer. So I just wanted to note with this that, so because of this team science voucher and our preliminary work, so a lot of this work has gone into an application for a career development award within the VA, which is similar to like K01 or K08, K23 within the NIH world. And so because we really needed to have some preliminary data that this is feasible, that we can predict, a lot of the work in this team science voucher went into this application for the Career Development Award. And I got word that it will be funded. And so we're starting the just-in-time process. And so hopefully we'll get that going, the award going towards the end of this year. And what we're calling the Career Development Award is based off of this whole concept of data to clinical action using predictive analytics to improve care for veterans with opioid use disorder. So we have taken the team science voucher team and expanded a little bit for the CDA, or the Career Development Award. So the primary mentor will be Michael Couture. Secondary mentors, Brad Martin and Teresa Hudson. Content mentors, Keith Bush and Adam Gordon. And consultants will be Sarah Landis and Tracy Abraham. So Mike is, again, a psychologist in treating OUD patients. Brad and Teresa are big data people. Keith is a machine learning person. Adam is our expert in the clinical aspects of MAT or MOUD. Sarah is an expert in implementation science. So once we actually have this thing and we want people to use it, how do we get them to use it is kind of her area. And then Tracy Abraham is my qual expert on helping me to do focus groups and other things and interviews to figure out what providers want in this type of tool. So here are the expanded aims of the CDA2. So we'll continue to hone this model, and what we're going to use now is looking at some machine learning methods to improve the validation statistics of the model, as well as explore other predictor variables. And then we're going to adapt the model into a clinical decision support tool to be used in real time with patients as they come into initiating buprenorphine. And so we're hoping that it'll also be able to display the risk factors that go with the predictive model score. And then in AIM-3, we're going to assess the feasibility of conducting a large trial with this decision support tool, as well as evaluating its acceptability among waivered providers. And really what waivered providers means is just those who are currently approved to provide buprenorphine care for opioid use disorder patients. So here's just a mock-up that we included in the Career Development Award application about what we might see that the decision support tool looks like. And this is really modeled after the STORM dashboard, which is the clinical decision support tool within the VA that's based off of the predictive model for opioid overdose. And so what it would just pull in is the patient's name, some information about the patient, their probability of continuation or discontinuation, the top risk factors contributing to the patient's risks, and some guideline links or something else to be listed here. So this is really the point of the focus groups, is to get together a bunch of experts and say, what would you want to see here with these risk factors if you're treating these new patients? And then some information about visits that may be already scheduled and different things. And as with all training grants, like the Career Development Award, they come with training activities, which are generally quite extensive. And so now that I'm on the verge of getting this funded, I'm like, oh no, I've got to go back to school in some sense. I don't know if I'm ready for this. But so training goal 1 is developing this expertise and predictive modeling using specifically the artificial intelligence methods, so machine learning. So I'm going to take a course with Dr. Bona, who's on here, as well as Dr. Pryor, and do some other things, some other trainings in that area. Training goal 2 will be developing qualitative research method skills. So I'll do some intensive training as well as some hands-on training and do a course within the College of Nursing. And then finally, developing some skills in implementation science, particularly around conducting RCTs using hybrid designs, which is where we're going if this clinical decision support tool actually gets off the ground. So that is all I have, and so I'm open for any questions you may have. Here's my contact information.
Corey, thanks for the interesting presentation, and congratulations again on your Career Development Award. That is fantastic. I'm curious. I know we've agreed before that you were going to take my natural language processing course, but I wasn't sure what the role of it is in that project. So yeah, is that just for fun, or are you planning to do something with notes in that data later on?
Yeah, so that's a really good point, because I didn't go through that here. So some of what we put into the what I call what we would do if situations, kind of if this doesn't pan out, what will we do? And so what I put in that section was if we aren't reaching our goal of 0.8 or higher, then I might start exploring what it would look like in pulling variables from the actual notes themselves in the EHR. So our goal was to kind of steer away from using the actual notes within VA at first, because that type of decision support tool obviously would get quite cumbersome if you're talking about pulling that information in. So I kind of wrote that as we would explore it if we're not getting great validation statistics without using that. And so I wanted to take the course in case we do have to go down that route. Plus, I just wanted to learn it. So
yeah, that sounds great. If you have or can get a protocol in place, I mean, you can make that your project for the semester.
Okay.
Yeah. Anyway, we'll talk more about that later. That's great to hear.
Thank you for your presentation and congratulations on the Career Development Award. That's really awesome. So we're happy to see that you got that. We will move on to our last presenter, Dr. Larson Pryor. We're happy to have her present. Go ahead and take over and tell us about your research.
So this is the title of our Team Science Voucher project, a transdisciplinary approach to reducing caregiver burden in Arkansas, which turns out to be quite a Herculean type of task. And these are the people who are part of our team, many of whom are here with us today. And this really is an interdisciplinary team. We have a number of people from the informatics group, Corey, who you just heard from basically public health, Jennifer Gann, who is in health literacy, Eliza Brown, who's done a lot with telehealth and is in the neurology group, and Meredith Atticott, who's with me in the PRI, but we have slightly different. Meredith is actually an addiction researcher and has a lot of interest in basically stressors and the role of stress in her case in addiction, but we're using a lot of her ideas. And then myself, whose research is in neuroscience and cognitive neuroscience predominantly. So this is a completely new area for me. Our first objective, we had 3. This is actually quite an ambitious project. So it's going to be continuing on. Our first objective was to use biomedical informatics tools to define caregiver perceived burdens, with our primary focus being on mental and emotional health, which we hypothesized would be a major issue. There are currently a number of public fora in which individuals can interact with others who face similar health-related challenges, and this can be from the level of the patient themselves. In many instances it is. There's Patient Like Me, for example. There are a number of groups that are specific to particular disorders, and the people who suffer from those disorders have the opportunity to talk to others like them. And in many cases, these are disorders that are relatively rare, as Dr. Fawcett was talking about. So there are people who wouldn't necessarily have anyone in their immediate area who themselves or whose children or parents had a similar problem. So it gives them the opportunity to talk to individuals, even individuals with a rare disorder who are suffering from the same problems. We began this with the idea that these posts would offer unique insights into the concerns and challenges that were actually faced by patients and their family caregivers. We were particularly focusing on unpaid family members who are in the position of providing care to someone who has a chronic disorder. We really were focusing on chronic disorders. So these are people who are looking at long-term caregiving responsibilities. In order to address this, our team collected publicly accessible posts from the Reddit platform and a caregiver discussion group. And in trying to prepare this, I went out, and it's really easy to find this group. And the data were collected from the period 2008 to 2020. And you're just seeing down here an example post. And we'll talk a little bit more. The question was, how did we want to go about analyzing these data, which, as you can see, I'll just go back to this, are free text data. So the team began with the assumption that they would start using natural language processing. So what is natural language processing, and why did that seem like a reasonable thing to do? This is a technology that's actually used to help computers understand human language. The majority of natural language processing methods, which I'm now going to abbreviate as NLP, rely on machine learning to derive meaning from human language. And you actually already know about this because you use it. If you've ever used Google Translate, that's actually an NLP algorithm. Microsoft also utilizes it. One of the tools they've developed using NLP is a Grammarly, which does the nasty, really annoying grammar checks on all of your Word documents. Certainly, it's been used a lot in trying to enable computer-generated interactions between humans and machines. And so if you've ever gotten, and I'm sure you all have, a call center with interactive voice response, that's an NLP application. And it's also, of course, in personal assistance applications like Siri, Cortana, and Alexa. It is a methodology that sits at the intersection of computer science, artificial intelligence, and linguistics. So why would it be helpful to us? So I'm sorry to say, the one that I did provide initially, you could read. This one you actually can't, but here's a Reddit post, and I cut and pasted Reddit all over the place to do this. So I'd like to point out this. There's always a little splash page on the side, and it tells you something about the community that, and the community that you're being engaged with here, in this case, caregivers, and the rules of engagement, how you're supposed to comport yourself on this site. And so here you have a little bit about the community. Taking care of a loved one is difficult, especially if you are dealing with guilt, pain, and fear on your own. And we are here to support you. So in this forum, there are currently 6.7 thousand members posting. So we as human beings, we can read this post and we can see not just the words that are there, but the meaning. We can see that this person is physically exhausted, that they're very frustrated, that they may be angry. Several of the posts will say, I feel so guilty. So we can see that, we can read it, we can understand what that's saying, but a computer can't. So we need to have some way of taking this free text information that a human reads easily and asking, what does a computer need to understand what a human understands from this post? And that's what the NLP algorithm is trying to help us do, so that we don't have to read through 6.7 thousand people's posts, and they don't post just one, and every post has the ability to be commented on. So you would spend the rest of your life doing this. Plus you'd forget what you were doing in this time, so the computer won't forget. So this is a good thing about computers. So this is why I want the computer to do all that searching for me. But before I can do that, I have to give the computer a basis on which to do that translation. So the computer can't just look at it and say, oh yeah, I understand everything you do. I have to give it some information in order for the computer to be able to translate it. So this is an actual snippet. So you can see that set of information over here. How do you create a post? What are the rules? And here is a set of posts. And what I'm showing you here is here's a post. And then there's the opportunity for people to comment on that post. So you can collect not only the post itself, but also a set of comments. And we have done that for every post. We also collect the comments that came. In this case, the post is short. In the previous slide, the post was very long. So the information, the actual number of words in a given post is very highly variable. So, and that means that the information content is, so depending on how a person writes, right, there could be a whole lot of vacuous stuff in there and a couple of pieces of really interesting information, or the whole thing could be full of something that's really useful and important. So we can have lots of words with little content, few words with lots of content, or even lots of words with lots of content. And so we have to decide, we have to find a way to teach the computer what words are important, what words are not important, what words convey meaning that we want to know about, what words don't, etc. So initially, here you just see a set of content. Here's the submissions that were actually pulled, and here's the comments and the frequency with which they are related to caregiving in some form, because the term that we were looking for was caregiver. But of course, we have to go beyond that. So this was work by Kate Schultz, who's on our team and is a student of Dr. Bonas. So she did text processing. So she's looking at these words and just asking the computer to pick out words. She used the Python natural language processing toolkit, and she extracted a set of themes based on these words. And some of the common themes that were extracted included access to care, social support, and then concerns about mental and emotional health. This is a visualization of this that Kat has done. And this map right here actually is interactive. So in her algorithm, you can click through it. And if you click one, you'll get a list of the terms that were associated with it. So she clicked this 130. And unfortunately, the list of terms isn't terribly useful for us in terms of what I'm trying to talk to you about, but it gives you the idea. So there are this set of words associated with this particular theme that seem to be related to one another. And she did this for a number of different terms. So this was an initial investigation into how we can get the computer to do this, to provide useful information for us. And our next step in this, and I'm going to see where I am in my, our next step in this process is actually to start to pull some of these phrases, randomly convey them to all of the team members, and have the team members begin to say, we think this is relevant. This is what we're looking for. So we're going to provide the training that the algorithm can then use to assign meaning, to tell us what it is we want to know about. So this is still very much a work in progress, despite considerable work and considerable analysis that's already been done. Lots more to do. Our second objective was to actually talk to people who were family caregivers, and then to try to talk to people who provided resources or services, which we're calling stakeholders, specifically in rural and urban Arkansas communities, with an initial idea that there would be differences in what we see in individuals who live in rural versus urban settings. And to accomplish this goal, we turned to an amazing resource that if some of you, now of course all the people that are working on my team know about this now, but if you don't know about this, you absolutely should. So this is the community engagement service that's offered through the TRI and led by Dr. Kate Stewart, with a really exceptional team that includes Ginger Morgan, here I'll even point them out, Ginger and Nikki and Rachel, who are all fantastic and amazing. And I'm sure there's a number of the other people on this team who are equally amazing, but this is an unbelievable resource. So we worked closely with this team, they were wonderful, to produce 2 community review boards, one in which we spoke with Arkansas caregivers, and one in which we spoke with these stakeholders, people who provide resources and services to caregivers. So on the first CRB, we had 12 individuals participating. They cared not only for adults with mental and physical disabilities, but 4 of them also cared for children. And in the second, we had service providers, and of course, COVID had hit. COVID had hit when both of these were put together. And so we were doing everything via Zoom. And there was a lot of difficulty getting service providers interested in in joining in. So we ended up with only 4 individuals in our second CRB. One individual worked as a disability rights advocate, and that individual had a child with Downs. There were 2 people who were facility administrators, and then there was a developmental center worker, and that was also working with children. That individual also worked with children. Okay, so here's what we asked our caregivers. We asked them about the challenges that they faced, the programs and resources that were available to them and their utilization of them, any challenges that they faced that were specific to where they lived, which was where we hoped to get at the difference between urban and rural communities, And then an open-ended question of, if you could do anything in the world and create a new tool of resource, what would it be? And from the responses of these people, we identified 6 primary problems. The first, and perhaps the greatest, was the lack of coordination between medical service providers. So everyone had the issue of having someone who needed medical care, had a number of different problems, and they could never get a single block of time that allowed them to get to all of their service providers. So that made the challenge of literally just transporting people to and seeing to it that they got to medical service visits Herculean. And then, of course, bleeding into that was transportation. There's, first of all, the time pressure that we just talked about, but there was, for individuals with physical disabilities, just finding appropriate transportation, getting the person in and out of that transportation, transporting them to and from medical visits, all of those kinds of transportation problems, added time stress, added physical stress, and added to this coordination problem. Interestingly, even though I have this as number 3, it probably should go as number 6. Financial stressors were not a major component from the group that we talked to. The lack of time away from their duties as caregivers is something that many people pointed to. But I would say what should really be there as number 3 is the lack of support services. And this was not just there are no services, although that was a problem. But this was, even if there are services, we can't get to them. We don't know what services actually are out there. And we've had to work 5 years with 16 different people to figure it out. And now that we do know about it, there's a 10-year waiting list. So from multiple sides, the lack of support services and resources is a huge problem. And then in the case of individuals with specific problems, sometimes related to where they live, there is a lack of appropriate local medical expertise. So then we wanted to know, what about people who actually provide the care and the resources? Because there are resources out there. So we asked them to describe their relationship to the caregivers they work with, the successes or challenges they've encountered. And of course, at this point, we're interested in what's the effect of COVID. Is there anything we missed? Is there something we should ask you about that we didn't think of in terms of a challenge? And then we asked them this open-ended magical wand question as well. We had 4 individuals, very different aspects of providing resources or support. Some of them were literally, if you will, in the trenches. They were literally working with caregivers or they were providing respite care. So one of these individuals was running a respite center. So I couldn't pull out specific agreed upon issues that this group could identify, but they identified one of the major problems that the caregivers themselves had done. And that is that federal and state assistance programs are underfunded, difficult to access, and too many people don't even know where to go to look for them. So this is just a huge problem. It was a problem in what caregivers told us, and it was a problem reported by the people who actually provide the services they're trying to get to. Again, lack of information available for programs that are actually available in Arkansas. So if you're trying to go for this for Medicaid programs, there's a 10-year waiting list, but PASS is one of the Arkansas programs that's supposed to help you do that. And a lot of people don't know how to do it. They don't know how to get access to it. And even if they did know how to get access to it, they don't necessarily know how to fill out the forms. RHIP is another one. This is largely, I think, financial, but this is another one that a lot of people don't know about. One of our caregivers pointed out that she found out about it sort of by accident, and she thinks everybody should be told about it up front if they have, particularly if they have children who have medical disabilities, and they're never told. Then other problems that the service providers pointed to is the lack of internet access, particularly in rural communities, language barriers, and that's not, I mean, I think we're all being a little bit more sensitive to language barriers in medical and health encounters, but they're talking about a language barrier in simply figuring out what kinds of resources are even available to you. The language barrier that our internet access is all in English, and if you don't speak English, how do you understand what it is you're trying to get to? Maybe you could use Google Translate, but that's a different issue. And then ADA noncompliance, in not just being unable to get access to buildings, but think about it. ADA noncompliance actually even still exists in some of our health and medical care facilities. If you have a disabled individual, how do you get that wheelchair up? If there are no ramps, how do you get them to the place? They even talked about ADA noncompliance when you're trying to provide service via telehealth. What does the person do if they can't hear? What do they do if they can't see? So ADA noncompliance was identified by service providers as a problem. And then, apropos of everything, a lack of funding. There's just too little public funding for this important service. And I think one of the things that our team is learning here is just how big a problem this is. We think of individuals who face these kinds of caregiving issues as being like 1 in 100 million, and they are not. These are not uncommon problems. And with an aging population, they're going to get worse. And our third objective, actually, this is part of the informatics objective, but I'm going to put it in here as a third objective because in a way it's looking like that's exactly what it's going to be. We decided that we wanted to put together a survey. And this came out of early meetings. It wasn't really part of the original plan per se. Our original plan was to work more with the community review boards, but given COVID, we thought maybe a survey would be a good idea. And the idea would be to provide ourselves with a broader sample of the state of Arkansas, because of course the CRBs, which are held in Little Rock, or that we were originally thinking we would hold them in our AHAC facilities, which would have given us a little bit more representation in really more rural communities. But we have that telehealth problem. So we decided a survey would be a good way to go. And so Jennifer Gann and Aaron Kemp created the REDCap survey, and the whole team helped with what do we want to ask and how do we want to ask. And it was deployed the last couple of weeks to Facebook with assistance from David Robinson from the TRI. And to date, we have had about 40 responses. Only 30 individuals actually completed the survey. So you'll see that. And this is a little map showing basically the zip codes of the people who responded. There's also one person down here from Louisiana. So we got, with that smallest data set, I was really impressed with the coverage that we have in Arkansas. And you can see this is clearly broader than the coverage that we got with our CRBs, which was fairly localized to the Little Rock area. So it's doing what we want. This is a picture of the splash page of our Facebook ad. And so one of our team members, Dr. Brown, I said, you know, we really ought to think about what our demographic is on Facebook, because I'm kind of curious about that. So she went out and found out. And unfortunately, it met what I thought it was. So in Arkansas, Little Rock and Bentonville are the primary users of Facebook. Most of the users, something like 50%, are female, and the age trends old, 34 to 50. So, oops, we're going to need another way to get this survey out there to get a broad representation. I'd actually heard some of this information that Facebook was definitely trending older for people who would respond, and so we're going to miss some caregivers that we know exist. From the Reddit post, we know that a lot of people are caregiving very young. They're in college, or they're still in high school and they're caring for a parent, or they're caring for a sibling. So we don't want to miss the people whose caregiver responsibilities are in that age demographic. And at the moment, our solution for this, I'll get to this in a second. At the moment, our solution for that is to, I'll put this into the future services and the future goals component at the end, but right at the moment, the idea is to deploy the survey through UAMS clinics. Of course, that's not going to get our quite as broad a representation, and then through the AR research program. And then Jennifer Gann has some contacts also where she can disseminate this through alternative methods. So hopefully we'll be able to catch some of the individuals who we miss with the Facebook ads. So amazingly, we have enough preliminary results to actually take you through what our survey did. And what I'd like to do is I'd like to ask you to keep in mind what we got from our CRBs and our stakeholders for information also as we go through this. So as we had hoped, all of the respondents were unpaid and the majority were family members. The majority provided 24/7 care. So these people are not providing care a couple hours a day or even a couple hours a week just to take someone to and from a grocery store. This is 24/7 care. And that's the 30 individuals who completed the survey, every one of them. 53.3% are caring at that level. The majority of care recipients lived in their own homes. The majority of caregivers were married, almost 60%, white, female, and college educated. Of 27 respondents, 19% worked full-time, but the majority were retired. However, you see that's a third, the rest of them worked part-time. Of 27 respondents, the household income was between $20,000 and $39,900 per year. So as a just general idea of the demographic we have to date. The individuals they cared for had several different chronic conditions, dementia being the predominant one, that's here, but we also had cancer, stroke, physical disabilities, mental disabilities, TBIs, and there were a couple of individuals caring for young people. The majority here are caring for adults. Like I said, it was generally 24/7, and it included, as a result, a broad range of responsibilities from transportation, household assistance, physical and medical care, to emotional support. So the largest ones were transportation and household chores. But you can see that's just almost all of them were just doing everything. And going back, you notice that the two major ones were transportation and household care, household chores. Remember that our CRB groups also identified transportation as a primary challenge. So early results of the survey served to support this as a major challenge. And these individuals aren't even traveling as far as we suspect some people have to, 6 to 20 miles to get to the healthcare providers that they need to see. And over here, what we're looking at is the self-reported place where individuals live, and the majority of them report living in rural areas. All right, so what kinds of personal challenges and stressors were identified? Emotional stress was ranked as the most burdensome. So over here, you can see the highest is green, the lowest is blue. For emotional stress, there was nobody who said there was no emotional stress. And the vast majority said that the emotional stress was high. So this was the primary challenge identified by our survey recipients. The next was physical stress. And now we just have to think, because if you look at some of those Reddit posts, this is a lot of what you see. I can't pick him up. I don't know what I'm going to do if they fall. I'm going to break my back if I have to continue to support this individual as they walk, or I'm afraid that I can't support them. What happens if they fall? They'll take me with them. Then what would we do? And finally, financial stress. where really a fairly large percentage, 20% said not at all, but you notice we're about 30-30 for extremely and somewhat. Because this is my research area and I'm very interested in it, I thought I would report what we got in terms of sleep. So the lack of sleep associated with 24/7 caregiving is a commonly reported issue on the Reddit posts that I went through. Sleep durations of less than 7 hours a night chronically and poor sleep quality are known to result in poorer mood, and they likely add to the emotional burdens of caregiving. And we're not just talking about the fact that individuals who are doing 24/7 caregiving aren't getting a lot of sleep. We're talking about the fact that their sleep is highly fragmented. So they might go to bed they might go to bed early, just saying, my care recipient, I can put them to bed at 9 o'clock, I can get all the things done. I can put them to bed at 9 o'clock, and they're up at midnight, and they're up at 3, and they're up at 5. And you're going to be up with them every time. So it's not just less than 7 hours, it's highly fragmented sleep. And high fragmentation sleep is also associated with poor mood. And ultimately, guys, not just poorer mood, but poorer physical health. So in our survey, our respondents reported an average of 6 hours of sleep per night and poor sleep quality. So a huge unmet need. There's no way you're not getting up with somebody you love who needs medication 2 times during the night. You're going to get up. So what do you do? What do we do to support these individuals who need their sleep tonight? Their sleep too, because the next day they're going to have to get up and continue to caregive for this individual. Okay, as our CRB members reported, and we see in many Reddit posts, survey recipients indicated that caregiving resulted in the loss of self-care. They're unable to care for themselves, they don't have time. So the burden on personal time, the majority of people report as extreme. And a frequent comment that you see on the Reddit posts, and something that was brought up in the CRBs, but to be honest, a little bit more by our stakeholders, by our service providers, is the fact that there's no time for yourself. It's not just that there's the emotional burden or that, but there's no time away from caregiving. There's no way to not be there. Even if you sit down on the couch for a few seconds, you know that person is in the background, maybe needing something you're not giving them right now. So there's just no time. And that's going to be a huge addition on the emotional burden that people have. I was surprised in our survey result, therefore, to see that virtually none of the individuals who reported to us use support groups. So in our caregivers CRB, a couple of individuals reported that those support groups had been lifelines for them. This had been a way for them to talk to people who were caring for someone like the person they were caring for. And to be honest, to talk about what it meant. So Dr. Fawcett was just talking about a disorder in children, that you have a child and you know their life expectancy is short. That is horrible. And the opportunity to talk to other people who are going through what you're going through, they found that supportive. And so I was really shocked to discover that we had so few people in this survey who used support groups. The primary reason that they cited is simply they don't have any time. And they reported that in a couple of ways. They didn't just say there's no time, although that was the longest. Then it was, it's too far away, I can't get there and back, takes too much time to go anywhere. It really all revolved around, there are so many demands on my time right now, I don't have time for any more. So the next thing was, okay, fine, I understand this is really terrible, but if there were a way to get a support group to you, would you even consider joining one? And the answer was largely no. Of those who said, yeah, I might consider it, their preferred mechanism was online. Of course, that means you have to be able to get online, but you can see the beauty. If time is the major problem, I mean, we're all facing it right now, right? If time is the major problem, then getting on a Zoom call takes 2 seconds and driving takes half an hour or more. So right off the bat, I've saved myself an hour, 30 minutes getting there, 30 minutes to getting back. And all I have is the time devoted to this person. Now, of course, the other option for this, and online doesn't necessarily mean Zoom, although that was one of the options that we gave them, is, well, there's these internet support groups like Reddit, like Patient Like Me, so those are another possibility that people can use. People clearly do. I was so surprised to discover that this particular group of individuals doesn't, but they did identify as largely rural, and that may be the problem. They just don't have the access. And Microsoft PowerPoint decided it has the problem. Microsoft has a problem. Aren't we all sad? Okay, let me see here. All I have to do is get back to this. Hang on. I have one more slide. Can you believe this? Okay, we're back. So for our future directions, our NLP team, as I said, is continuing to work with the data, and we will continue that process. The Facebook survey will be open another couple of weeks, and we really hope we get data from up to about 100 respondents. Then we'll deploy the survey in clinics and in the AR research group. We have a Spanish language version, and so that has been approved. So we also will be hopefully deploying that. And then we plan to explore the caregiver support mechanisms available here at UAMS. We've already met with individuals from the Arkansas Geriatric Collaborative as an initial step in this process. I've also talked to a researcher who's looking at patients with chronic heart failure and has a caregiver survey for the caregivers for those individuals. She's very interested in the whole issue of how can we provide support for caregivers and what kind of support would be most useful to them. So hopefully we can establish something there. Our team is already thinking about if there's only one thing we could do that might help, the one thing that we think would be the most useful is to try to tackle this question of some kind of harmonization for medical visits. It should be possible to do that, at least within UAMS. And so that's one of the things we think we might be able to provide a case for to administration, and we might be able to do something about. It was certainly identified as a huge problem. So that's probably one of the first places that we'd like to tackle as is there something we can actually do? It's really nice to collect all these data, but at this point in time, I think our entire team is on the front of, but we'd really like to do something to actually help. That was where we started from, and that's where we'd like to end. So I like how we all have different, hello, anybody have any questions? But before I come back to questions, I'm going to thank our team. As Corey noted, it certainly does take a multidisciplinary team, especially if you're walking into an area that you've never been in before. And I think that's the case for all of us on my team. So all the credit and kudos goes to the entire team, and we will continue to press forward with the effort. And I guess I won't take questions because it just decided to disappear. There we go. So I'm happy to answer any questions if anyone has any.
I don't really have a question, but I think it's very interesting to note that if you look at the way Arkansas Children's tends to do a lot of discipline visits, they have those multidisciplinary teams where they have those different clinics and different clinic days. it's I think maybe worth noting, like, why aren't we doing that? Kind of like you were saying, why aren't we doing that in an adult population? And that's something that they actually talk about as these kids transition into UAMS and these adult care, that they lose that team, you know? So I was going to make note that I thought that that was really important to make note of, and thank you for bringing that up.
Yeah, thank you.
Seeing no more questions, I'll just thank Dr. Larson Pryor for her presentation. Again, another interesting presentation. Thank you, everybody who was able to come today, and we will have this recording available probably in about a week on our website. So feel free to tell your coworkers about the cool presentations and invite them to the website in about a week to come watch them. But that's all we have. Thank you so much. And we will have our innovation series back again, probably in August or September. But thank you, everyone. Really appreciate it.